Hi, Roxana, Ajay, welcome. So it's a pleasure to talk to you today about the value of imaging in calcified lesions. These are my conflicts. So as you know, calcium has been an old foe. That was already recognized in 1979 when Andreas Grunzig actually published in the New England Journal of Medicine that at that time, balloon dilatation technique is limited by anatomic factors such as calcified lesions. Calcium is a problem and it's very frequent. As shown here in this slide, showing you that the incidence of calcium is substantial, with up to 20% of the cases of coronary artery disease having severe calcifications, and this number even goes up to 80% in patients with peripheral artery disease. Calcium, though, is more frequent in patients with advanced age, diabetes, lipidemia, hypercholesterolemia, male gender, smoking, and very importantly, renal disease. And calcium is also a predictor of worse outcome in stable patients, but also in unstable patients. As shown here in this meta-analysis published by Philippe Généreux a few years ago in JACC, showing you that the more severe the angiographically visible calcifications are, higher MACE rates are up to 1 year. You see a triple number of mortality, and you see MACE rates that are virtually double in patients with more severe calcifications at 1 year in patients with ACS. So the reason calcium is challenging because it often results in difficulties in completely dilating lesions. Calcium predisposes the procedure and makes it prone to creating dissections and hematomas, and it may hinder the delivery of devices, which substantially usually results in longer treatment times, more resources, a longer hospital stay, and higher costs. And very importantly, might result in cases like this with severe stent underexpansion. And please recognize and remember this within this talk, stent underexpansion or small minimal stent area has been shown very consistently to be the most important predictor of PCI failure at the short and longer term. The issue, though, with calcium is that it is angiographically only very poorly visible in many cases, since angiography is only moderately sensitive for the detection of extensive calcifications, with a sensitivity of 60 to 85% for 3 and vessel, 3 and 4 quadrant calcifications, as described by Gary Mintz many years ago in Circulation. Also in this case you can see an LAD with angiographically only relatively mild calcifications, but if you would have done an IVUS in this case you would have seen 180 degrees of calcium in the distal segment, a lesion that actually was not that apparent on the angio, with a reference area of 7 bit more proximal, and in the proximal segment at the bifurcation with a diagonal 270 degrees of calcium, which really went into the bifurcation with the circumflex. So it is clear already that IVUS and OCT clearly allow better appreciation of coronary calcium. With two distinct features within IVUS and OCT, IVUS clearly allows you to accurately and relatively easily assess the arc of the calcium and the length, while OCT provides you a bit more information, as it also gives you information about the arc and the length. But importantly, and we'll get back to that in a second, also gives you information about the thickness of the calcium and the depth of the calcification, which is better appreciable on OCT as compared to IVUS. So the reason that scoring the amount of calcium in a invasive imaging pullback is important is shown by two studies I want to share with you. One on OCT, which is this one, showing you that if you classify calcium with the arc of calcium being 180 degrees or more, the thickness of the calcium, remember the cutoff, in this case 0.5 millimeters, and the length that is calcium visible, that calcium is visible along the pullback, you all earn points. The more points you get, the higher risk you will have to ending up with small stent suboptimal stent expansion. And the same was shown in an IVUS study. Also here, if you classify the amount of calcium based on IVUS, so again the criteria, the arc of the calcium, in this case 270 degrees, the presence of calcified nodules, calcium in vessels smaller than 3.5 millimeters in diameter, and the reverberation arc as shown on the right bottom panel, which illustrate what that means. You also get points, and also here the more points you get, the higher the likelihood that you end up with a stent expansion that is far from optimal. So at the end, it's clear it's all about fracturing the calcium, which can be done in many ways. We will get back to that and also in the next lectures. And at the end, what is very important is that you use imaging to see if you created fractures in calcium with either type of plaque modification technique. In this study, 61 patients with severe calcification, cracks were found in 48% of the cases, were more frequent after cutting balloon or rotational atherectomy, and resulted in significantly larger stent expansion. So if you do see cracks and if you do see fractures, you will end up with larger stent expansion indices and, very importantly, lower rates of binary restenosis and TLR up to 1 year. This is a very nice overview of imaging in calcium published by the group of Lawrence Reiber from Bern in the Radcliffe Cardiology Journal last year, showing you the mechanisms of stent expansion. On the left side, a panel in which you can see the effect of balloon dilatation to eccentric calcification. So if you calcifications with an arc less than 180 degrees, you can see that balloon dilatation clearly impacts the lumen area. So the lumen area increases, but this is mainly due to the fact that you create dissections, and most often hematoma, on the opposite side of the calcium, because that's where the resistance is the lowest. And finally, you will usually be able to create adequate stent expansion in these cases with eccentric calcifications. In the middle column, though, you see the effect of balloon dilatation to thin but concentric calcification. So in this case, they measure the depth of the calcium, in this case 0.3 millimeters. If you do balloon dilatation, you create dissections and you usually create cracks in the calcium, which finally may help you to achieve adequate stent expansion without going to more aggressive lesion pre-dilatation or atherectomy devices. On the right side, you see an image of very heavy calcification, thick calcification with chunks of calcium with a thickness of over 1 millimeter. And this is nice because you very nicely can see that balloon dilatation with high pressure non-compliant balloon virtually does nothing. You see no increase in lumen area and you see no cracks in the calcium, which clearly explains the lack of an image on the bottom right side, because stent expansion here would not be recommended. And this lesion would clearly yield some more aggressive work before you would proceed with stenting. So if you would look for an algorithm, I would like to point you to this very nice state-of-the-art review by the group of Adrian Benning, last year published in JACC Intervention, and showing you with a very nice, or let's say proposing a very nice flow chart, and again, the same 3 criteria for severeness of calcium, so being the arc, the length, and the thickness. And based on that, the algorithm would point you to either balloon dilatation or more aggressive pre-dilatation, or lesion preparation with orbital or rotational atherectomy, or lithoplasty, as will also be demonstrated later in this session. This again is then a case we just had recently in our lab. It's a heavily calcified LAD, an OCT pullback, and you can very nicely appreciate the way that OCT provides you with an impression of the severity of calcium here at 5 o'clock, very thick chunks of calcium. Also here, after balloon dilatation, you see the effect. So you see tears in the intima. You see the lumen got disrupted, but the chunks of calcium are virtually all intact. In this case, we proceeded with a shockwave balloon, and watch at 2 and 3 o'clock, you see clear cracks even within the thick chunks of calcium, which clearly illustrate the fact that with cracks in the calcium, this is the go-ahead to proceed with stent implantation, and these cases will end up with good stent expansion. So finally, I want to end with a short case showing you all the things I've just shown you in one case of a 60-year-old male presenting with stable angina in this significantly diffuse disease LAD, with in this case clearly appreciable calcium on the angio. So we proceeded FFR 64, and we wanted to go ahead with imaging. Imaging, however, the IVUS, in this case the Boston IVUS, did not cross, and we proceeded. We proceeded in this case with a rotablator with a 1.5 millimeter burr, and then thought, you know what, let's try some ballooning. We used 3 balloons, 3 5 non-compliant balloons. They all broke, and then we thought, you know, this must be a case for the shockwave. So we proceeded, shockwave balloon 3012, inflated to 4 atmospheres, and puff, balloon broke after 2 pulses. So what next? I want to show you this case because here also with IVUS you can very nicely appreciate all the things that you can do, or that we did in this case, to torture this vessel. with different types of technologies. And in this case, the lipid scan pullback shows you virtually all things that we've just have seen. So you see on the bottom left panel, you see let's say relatively healthy reference area. But if you go to the top panel, second from the left, you see the nice effect of the rotablator, which clearly created a very smooth tunnel of approximately 1.5 millimeter, exactly the bird size. One image to the right, you see a large hematoma in the LAD, which was the result of the non-compliant balloons following high pressure dilatation on the opposite side of the calcium. And very important, on the bottom panel, second image from the right, you still see this concentric ring of calcium, which did not yield after all these types of maneuvers to crack the calcium. And on the right bottom, you see this chunk of calcium protruding in the lumen and explaining all the balloon ruptures. So in this case, we were only able to crack this lesion with a Wolverine balloon and ended up with a good stand expansion. So with that, I want to conclude by saying that moderate to severe calcifications are frequent. They are often missed on routine angiography. They negatively impact the result of stenting. And importantly, pre-PCI imaging allows for a better appreciation of calcium. It will help you in guiding plaque modification strategies. I would like to urge to repeat the imaging, which allows you for assessing the effect of the plaque modification technologies. And finally, post-PCI imaging allows for assessing the proper stent expansion, because please remember, small MSA is the most important predictor of stent failure. And with that, I would like to conclude and thank you for your attention.
Joost, that was fantastic. Thanks so much for that. Quick question for you. What percent of imaging, or what percentage of calcified lesion cases should have imaging?
In our lab, I would say virtually all of them. If the lesion is long and if you have any doubts, try imaging. Do imaging. Because I'm a true believer, and I'm pretty sure that the use of imaging will result in larger stent areas and better long-term outcome, as has been shown by up to 8 to 9 randomized controlled trials thus far.
I think that's a really good point, and it actually leads us to some nice discussion amongst our panelists. I think, first of all, thank you for that talk. It was really great. First and foremost, and just to kind of follow up on Ajay's question to the panel, I think it's just not realistic to say that we have to image every single calcific lesion. I think it would be ideal to do that, but we know that that's not what's happening. So why don't we get to the real world, and maybe Didier Tchétché could tell us what exactly is he doing in his lab. And then when you do choose imaging, I personally, I'm much more used to IVUS, and now I'm seeing a lot more utility of OCT. And you told us that the additional value of OCT in understanding the thickness of the calcium, as well as the penetration and the effect of the treatment, those are really interesting. So I'd like to kind of just go around. Let's start with Didier. What are you using? And if you are using it, when are you using it, in whom, and which one, which device?
Thank you, Roxana. The issue here in France is reimbursement. We have, so there is an economic issue. So we have to be a little bit selective. So I don't use it in every single patient, although I would like to be able to do so. So we are mainly targeting calcified left main. All the left main lesions are imaged, and we start here with the OCT. Also, if we have a bifurcation that may be calcified, we tend to use imaging quite frequently. But we have to be selective, because we know that we cannot afford to use it in every single patient, although it would be the case in an ideal world. So left main and calcified LAD bifurcation lesions.
Azeem, how about Montefiore? What are you doing? What have you done there? I know you guys are now incorporating imaging big time in your lab.
Yeah, absolutely. And I respect what Didier said. Reimbursement's an issue. We're an academic teaching center, so we have preferred that for the fellows and for their learning to use a lot of intracoronary imaging. So I personally use it in about 80% of my cases. because I'm teaching my fellows how to use it. If I were to say, and you needed to use them.
We lost him a little bit too. It seems like, and we'll wait until he comes back. But Ajay, you know, you're leading the largest trial on calcific lesions, the ECLIPSE study. I'm sure you're going to talk about it during your talk, but before you go there to give your talk, what are your thoughts? Have you actually incorporated that to try to get the best possible treatment benefit in your clinical trial, and in what percentage are you seeing that go up? IVUS, OCT, imaging.
Yeah, we're very similar to Joost in the sense that we tend to try to image every single one of these patients as a whole in our lab. We're imaging over 3/4 of the patients. Within the trial, part of the endpoint is actually an OCT-based endpoint, but that's a specific cohort of patients. But beyond that, I think what we find is that once we started learning that cracking the calcium was the key to expanding the stent, the only way to really tell that you've cracked the calcium is by doing intravascular imaging. You can kind of tell that the balloon goes up, but sometimes if you don't check it in multiple views, it can be eccentric, and that can be a problem. So with that, I think you know, imaging is really critical for these cases. And I'll illustrate that in my talk as I go forward. All right, well, I think what I'm going to do is focus a little bit upon debulking techniques in coronary atherectomy. I'm going to specifically cover laser, rota, and orbital, and then we'll have a talk following this on lithotripsy itself. In the next slide will be my disclosure slide, and I don't personally take any money from industry, but these are all the variety of grants, research support, and travel expenses, meals that I've had in the interest of full disclosure. To start off with, we covered this already through use, but it's really important that interventionalists recognize that it's not just getting the stent to the location, it's actually a combination of getting the stent to where it needs to be, but then also expanding it adequately, because so many of our trainees focus on getting it to where it needs to go, but if you don't expand it, then that's going to have bad outcomes. We also know that calcified lesions, in addition to making your life miserable in the cath lab, can also lead to more complications, not only early, but also late in addition. So here's just an example of that. If you look at this slide showing stent expansion in calcified lesions, it makes obvious sense. If you have a brick that's surrounding your vessel, your stent is not going to expand in that brick, especially as it becomes more and more concentric around the artery itself. So the arc of calcium is very, very important in determining whether stents can expand. Now, this is just one slide. There's several studies on this showing that not only is it a problem with acute complications, but late complications are greater in calcified lesions. Some of the highest rates of restenosis are seen among calcified lesions, and by the way, also stent thrombosis is also increased. Now, if we want to just go and illustrate this through a case, this is just a heavily calcified CTO case. It's a nice bookend to what we were seeing previously. I'll show you the retrograde in a minute, but very, very calcified. This was not thrombus, it was certainly calcification. And if you look at the retrograde approach, this was going to be misery, however you try to deal with this case. Now, surprisingly, in this case, a hydrophilic wire crossed after a short amount of manipulation. And I distinctly remember the fellow saying, oh, that's a good thing, the wire is down. And from those of us that do these types of cases recognize that actually the fun has only just begun, because now you have to get your equipment through and expand all this calcific disease. So what happened in this case is we like using a lot of equipment, particularly when we're trying new equipment out. So what we used is a whole bunch of different microcatheters, trap liners, balloons. We got the trap liner down and ultimately could not cross the distal part of that lesion. The distal cap could not be crossed. And we tried everything, microcatheter spinning, et cetera, et cetera. So what do you do at this point? Well, the real question is you have an uncrossable lesion, but a wire across. And so this is a perfect situation where the use of laser atherectomy could be helpful. Now, I'll talk a little bit about how laser works, but first, a few things about laser atherectomy in current day PCI. Number one, this is an ideal situation, a balloon uncrossable lesion with a wire across. There are other areas where you could use laser, in-stent restenosis due to underexpansion, and potentially severe thrombus, but I'm not going to go into those for the course of today's talk. So how does laser work? Well, it actually gives you a specific photochemical and photothermal energy going forward, but photomechanical is really how it affects atherectomy and how it changes plaque to crack plaque when you're dealing with severely calcified lesions. And so that's the distal and lateral effect that you can see. I'll show you a couple of videos that can illustrate this, or images that can sort of illustrate how we're taking advantage of this. The first one is based upon the energy, which is called the fluence. And basically, as you have higher fluence, you create a larger bubble, so more energy that goes on. Now, the flush medium is also important. On the right is saline solution, on the left is contrast. You can see why you want to favor saline, because you don't create an explosion with saline, whereas with contrast, you certainly would. And so that's why typically for these cases, balloon uncrossable lesions, you're only doing saline flushes. It's for underexpanded stents that you might choose to use contrast. So that's what we did in this case. And with the laser going at 80-80, we were able to cross successfully down beyond this area. And once we crossed, we could then start dilating. Now, what was the technique we used? We wanted to, again, maximize tissue ablation and minimize the photochemical effect. We didn't want to cause an explosion because the vessel wasn't stented. So we used heparinized flush. We advanced the catheter slowly, and we retracted the catheter so the catheter wouldn't melt on the wire, and we were able to achieve a successful result. Unfortunately, a balloon still wouldn't expand. So now what do? You got the wire down, you got a balloon down, but the balloon won't expand. And fortunately, there are a number of options that we can choose. There are many things, some of which we've already heard talk about, some of which are in the next talk, but I'll specifically speak to atherectomy in this particular circumstance. We have a wire down, we can swap out, and we can use atherectomy. The challenge is there's not a lot of class 1 data or good high-level evidence showing what to do with this next step. All of these algorithms are just algorithms that people have proposed, and through clinical experience, we've gained some knowledge about in terms of how they work. Joost already spoke to this. I'm not going to cover it in detail other than to say that whatever we do, we want to create a fracture of the calcium so that our stent can expand. And what we have seen is that as the longer the calcium is, the more the arc of calcium and the thicker it is, the harder it is to expand with individual balloons, and that's why atherectomy comes into play. So rotational atherectomy has been approved since 1993. This is the old system, been recently updated to the Rota Pro system, which gets rid of the foot pedal and allows you to sort of advance from above. Paul Tierstein, I heard once joke about this, saying it's a great system. He just couldn't figure out, how he could get his foot up on the table to activate it. Well, you don't have to do that. You can activate it with the button with your hand. And there's a generation 2 that's coming out over the summer. Now, Azeem and his group nicely showed that when they were in Milan, that if you choose upfront atherectomy versus bailout, your time of procedure is less, there's less contrast. This whole phenomenon of atherectomy regret goes away if you choose to use it up front. We also have some randomized trial data. This is just data from the Prepare Calc study. We actually saw Mohammed on the screen before, basically showing that your strategy was more successful without crossover if you did atherectomy up front. On the other hand, though, people could say, well, you were 81% successful with balloons only and you didn't have to cross over. And that's why I think we need larger randomized trials to sort of inform our practice. There are other atherectomy devices. This is the CSI device, which is approved in the United States. We think in Europe relatively soon. This does not have a foot pedal and basically acts by not only spinning this way, but also orbits. And that size of the lumen is actually achieved by sitting in the vessel for longer. So the longer you sit, the larger lumen you get with the same size device. Now, the randomized trial data in this device is lacking at present, but it was approved on the basis of the Orbit True trial, which was basically a trial that showed good efficacy and late outcomes that were quite acceptable, although you can see the overall rate of MACE was 23% with severely calcified disease because of the fact that these are higher risk lesions for restenosis. The MI events were very, very small. We are doing the Eclipse trial. Roxana spoke about it briefly. It's a 2,000 patient randomized trial looking at a balloon-based strategy versus an orbital atherectomy-based strategy prior to DES implantation. There will be endpoints that include not only OCT-based MSA, but also late clinical events to hopefully show benefit of orbital atherectomy in this particular lesion subset of patients with severe calcification. The reason this is important is because very few hospitals actually do atherectomy. In the United States, a third of hospitals perform no atherectomy, and we feel that overall, because of concerns of complications, justifiable, these patients are often treated by just sneaking a stent in, not adequately expanding, and perhaps causing worse clinical outcomes as a result of it. Now, there are relative advantages of orbital and rotational atherectomy. I'm not going to go through this in detail. These slides are actually available if you search my Twitter account. They're all available. You can see them. There are pros and cons to each. The reality, though, is that either can be used in most cases of severe calcification. You need to be facile at them in order to be able to use them and to lower the overall rates of complications as a whole. Now, the final angiogram in this case, after atherectomy, showed great stent expansion. We confirmed with an IVUS, just as Joost said, to confirm true stent optimization, and the patient did very well as a result. But we had to really use multiple tools in this particular case. So to conclude, I'll say, number one, the field of adjunctive therapies for calcific lesions is certainly heating up. But because of that, we have more data. We need to accept the fact that it's becoming more and more prevalent in the cath lab with an aging population, those with comorbidities and downstream presentations, medical management first, lots of statins, more calcification, and then they go to the lab later. These are among the highest risk lesions we treat, cause increased pain and suffering for us, certainly in the lab, hopefully not to the patient, also greater risk, and longer-term outcomes are worse with calcified lesions as well. And I'll end by saying, back to Joost's talk, imaging is a must because it not only helps you diagnose when you should use it, but it helps modify your treatment. We see the crack, we know we can go forward. We don't see the crack, we need to do more. And after lesion preparation, prior to stent implantation, those are both important points. And finally, for stent optimization to achieve the best results for your patient. So thanks so much for listening, and happy to take questions and go on for a discussion at this point.
Well, Ajay, that was a fantastic talk. Really, in a short 10 minutes, you covered so much. So my short question to you is, you're a big advocate of imaging, as I am, and I do believe that it's incredibly important, especially in this patient population with calcific lesions. In what way, I heard you say, and in your final slide, that you're using imaging to actually figure out which device. Could you expand on how do you choose which device for which patient? I mean, there are so many debulking devices now. You showed us laser, orbital atherectomy, rotational atherectomy. Which one do you choose in which patient, and how does imaging help you?
You know, you could write a whole paper on it. In fact, I know Margaret is doing that actually in an imaging algorithm, but I'll give a couple examples. So if you see calcium on the angiogram and you do imaging and the calcium's all deep wall, you don't have to do atherectomy, you can do balloon. Similarly, if you see a calcific nodule that's encroaching on the lumen, we hear a lot of talk about the shockwave device. It's probably less likely to be effective in that type of case, and you might need an atherectomy device. The other option, and the other way we view this, is if, let's say, it looks very calcified, but there's only concentric calcification at a short segment, then that might be something where we try a balloon first instead of spending the money on the atherectomy device or the shockwave balloon. So those are just ways we do it. You have to be good at imaging to be able to sort that out, and then you also have to know what will happen differentially, and we'll have more data with this as time moves on.
That's great. We have this great panel, and maybe we can go to Holger. And maybe in your experience, do you have a preference over one device over another, or are you using this kind of an algorithm, of an imaging-based algorithm, to choose your plan?
Yeah, so it's like always, yeah, we are using imaging, so very similar to Didier. We are also using imaging on a selected basis, because this is also a reimbursement issue in Germany. So that's the reason why we mainly use imaging for left main coronary artery disease, or for highly calcified lesions, where then based on this we decide what is the next step to go. Nevertheless, usually I start with a non-compliant balloon and try to crack everything, and if there is a crack, then based on imaging, then I decide to go for the next step, so implant a stent, or in case it's not cracked, so then you have to consider the next step. So sometimes we use, if it is highly calcific, we use atherectomy. rotablation, or sometimes we also use some other devices like scoring or cutting balloons. This always is depending on imaging. Usually my step up is first use a balloon, non-compliant balloon. Next step usually is using a scoring balloon, and then the next step it's rotablation. But I know that this is an algorithm what we use, but everybody is using it a different way, and some use imaging for it. So, but this is usually my way on how to treat highly calcific lesions.
No, that's good. Yeah, go ahead, Ajay. It's all yours.
No, just real quick. I'll ask Azeem, but then I'll come back to your experience, Roxana. This idea of balloon before atherectomy, there are many people who are scared to do it because it makes the atherectomy have more risk for complications. Is that true or is that not true?
Yeah. In my experience, it's not true.
Go ahead.
In my experience, it's not true. I think people, they have this misconception that if you balloon and you've caused some dissection, it means that rotablation is now contraindicated. I don't think that's true. I mean, we've often done rota after ballooning. I think the one concern I have in some of those cases when you don't do upfront rota is that if you've already ballooned and you started with smaller balloons and then you go to a bigger balloon, your residual MLD now is so large that maybe the rota is not going to be effective unless you use a very large burr. And I think that's maybe the downside of always ballooning. I think all of us are a little bit guilty of not doing enough atherectomy up front and often swapping around. I mean, we've all had those cases where you go, I just wish I'd started with atherectomy.
Totally agree. And actually, I'm going to ask Roxana, because her center does probably the most atherectomy in the world, a little bit atherectomy tips. One thing I'll say, though, I totally agree that you can balloon first. But if your wire, by chance, falls into a plane, and this is true whether or not you ballooned or not, if you're in this plane and it looks like it's on a bend or something like that, those are cases where atherectomy you really have to watch out for in terms of the complications. So Roxana, tell us what learning points for atherectomy for the audience. How do you avoid complications in your center?
Well, I think we have an algorithm that we follow, and it's very different than yours, Holger. I mean, as soon as we see angiographic calcium, then we are talking about we need to do some kind of an atherectomy device, and then we use imaging a lot actually in our calcific lesions, probably more so, especially in the left main and in bifurcations. But I wouldn't say it's in every single case. I can tell you that. But the algorithm is always atherectomy up front, never regretting not using atherectomy. It really truly is. And we're not really doing, there are some things that Dr. Sharma is doing. He's actually going to look at this in a prospective randomized study with Dr. Moses. I think they're going to work together on a very interesting way of combining rotational atherectomy with cutting balloon, as opposed to post-dilating with a regular non-compliant balloon, to really, really help shape how the atherectomy is being done. So there is a lot of different algorithms, but it definitely is right up front, very aggressive going over with an atherectomy device up front, whether it's orbital or rotational atherectomy. And I would come back to you, and maybe Joost is the big question, is that if you do balloon and get a dissection, that's when I'm worried about pulling out orbital atherectomy. I get worried because of the way it works, that it might have more of a perforation or dissection into the planes. Do you have any experience on that? Either one of you. I don't know if you're allowing that even in your trial.
No, there is crossover in the trial for legitimate reasons, and so we'll actually have good data on that from the trial itself. So cases where the balloon has failed in crossover. It is interesting just on the trial itself. A lot of people said nobody's going to randomize anybody with severe calcium. It turns out that the rate of severe calcium is really, really high based upon the core lab, and similarly, the rate of crossover is low. So people are actually randomizing the right patients.
Joost, did you have any comments on that before we go to Azeem?
No, I agree. I think I agree with Ajay. The issue is we don't have orbital yet in the Netherlands. We are about to get it, hopefully very soon. was not approved yet. But for Rhoda, I share the same thoughts on not being that afraid of continuing with Rhoda after filled balloon dilatation. But again, here I think the use of imaging and wisely using imaging could really help in also down tuning the number of devices you use. I mean, these devices tend to be much more expensive than the imaging catheters we use. So if you use your imaging, select wisely, then I think you can get a long way.
Thanks, Ajay and Roxana. And yeah, it is, lithotripsy is the new kid in the block, and hopefully gives our colleagues out there a new weapon to deal with calcified lesions that's hopefully easier to use and safer to use. And so I'm hoping that, you know, we'll be able to deal with calcified lesions in a better way. So I'm going to just briefly tell you what the system is, how it works, maybe show you a couple of cases, and then we'll see how we're doing with time. So this is essentially how you perform intravascular lithotripsy. It is a special balloon that is 12 millimeters in length for the coronary balloon, a semi-compliant balloon that facilitates the energy transfer. It has distal and proximal markers like all balloons do, but the difference is it has these two emitters that pulse once per second for about 80 pulses per catheter. The balloon is then connected to the generator that generates the energy. This is a monorail system that is deliverable over 0.014 guide wire, any standard guide wire, and really is delivered like any normal balloon would be delivered to the coronary artery. So the way you use the lithotripsy device is essentially, we usually try and deliver it as our first balloon. There may be cases where you can't deliver it and you dilate with a small balloon before using it. You bring it to the lesion, you inflate it at 4 atmospheres, and then you press the button on the connection, which then starts allowing you to emit energy. And what that does really, it expands and collapses a vapor bubble that creates these short bursts of sonic pressure waves that can be as high as 50 atmospheres. It then creates this local effect that really it will only contact and have an effect on calcium. It'll pass through soft tissue and not damage soft tissue. And so one of the benefits we've seen is that we've not seen long spiral dissections with this device. And if you look at this high-speed imaging of what an impulse looks like, it looks very much like what Ajay showed us in the previous presentation for using laser in contrast. So this is really a very much more focused way of creating this energy and creating the sonic wave that then moves towards the wall, cracking the calcium, but passing through soft tissue. So a very similar concept to what's used for breaking up kidney stones, but here done in intravascular way and in a very controlled way. So the balloon, the coronary balloon, comes in 4 different sizes, from 2.5 to 4.0. All the balloons are 12 millimeters in length. There probably will be other balloons in the future that are longer. Each balloon has a maximum possibility of emitting 80 impulses. And like I say, compatible with our standard wires and guiding catheters, this can be used either via the radial or femoral route, depending on your preference. So I thought I'd show you just a couple of cases that we've used shockwave in. Here's a patient with a severely calcified left main to LAD lesion, 66-year-old patient with normal coronary risk factors who presents with stable angina. And you can see this long lesion extending into the proximal LAD and a severe amount of calcium. We do tend to use a lot of imaging when we do these very complex lesions that are long, calcified, and involve the left main. In this case, we did OCT. And with OCT, you really do see these large, thick areas of calcification, really diffuse calcification in the left main and proximal LAD with large arcs of up to 180 degrees. So we thought this would be an ideal case for shockwave. Of course, you could use atherectomy here too, but we thought shockwave would be a safe and easy way to prepare this lesion. So we started more distally with a 2.75 millimeter shockwave balloon. And the way it works is you inflate the balloon to 4 atmospheres. When you're at 4 atmospheres, you then start emitting your first chain of impulses. And once you finish that, you then inflate to 6 atmospheres to get full expansion of the balloon. So really, you're trying to avoid as much as possible high pressure barotrauma and letting the sonic waves from generated by the emitters really do the work of cracking the calcium. The one thing to remember is that you need to have a balloon that really matches the vessel diameter as close as possible. And so if you're going to treat very diffuse lesions, where the proximal diameter is 3.5, distal is 3.0, you may want to choose, a balloon that can be used on both sides to avoid using multiple balloons. So here we used, 2.75 more distally. We then used a 3.25 balloon more proximally. And we did really multiple trains of using these impulses to try and break the calcium. So this is what it looked like at the proximal LAD after the initial impulses. We were not happy with the left main, and so we took a larger balloon for the left main. And even after the larger balloon, we still felt that the expansion was not as good as we would have liked. So we then went on to use an angioscalp and a non-compliant balloon, just highlighting how I don't believe there's one solution for all cases, and that you really do need to have a toolbox of devices in order to really treat the large complexity and variability of calcified lesions. So, initially when we used this, we wanted the shockwave to do all the work, but subsequently, as we've gotten more experience, we realized that using non-compliant balloons after the shockwave helps significantly. So here's the result after the shockwave. If you look at the proximal LAD where we only did the shockwave, you really see good expansion, no dissection. The only area of dissection you see is where we used the angiosculpt and the high pressure non-compliant balloon. And really, this has been one of the advantages of using this device. Another advantage of using this device is, as you can see here, we're treating a really complex disease. There's a bifurcation of the LAD diagonal. There's a left main bifurcation. And we're able to keep all our wires in without removing them, which with atherectomy, as you know, you may have to remove it. So here were the OCT findings after the shockwave. And really, you can see in certain areas very, very nice cracks of the calcification. After we were convinced that we prepared the lesion properly, we then went on to stent. We implanted 3 overlapping stents from the left main to LAD. And I wanted to show you what the final imaging looked like for this case. So here you see the baseline. This is after the shockwave, and then you see the final result. And besides the good expansion, notice how in many areas you get very symmetric expansion of stents, which I do believe is important for long-term outcomes. Here's the final angiography, really showing you, a great result in a very complex left main LAD lesion. So briefly, in the little time I have left, I want to show you another quick case, just to show you the versatility of this device. So this was an 86-year-old patient who was admitted with chest pain, respiratory failure, requiring intubation. He was diagnosed with having an NSTEMI. His ejection fraction was 35%. He also was noted to have severe low-flow, low-grade aortic stenosis with a valve area of 0.74. He was extubated after a few days, and a cardiac cath and CT were performed. And these were the findings that we saw. So clearly he saw the cardiac surgeons who thought he was not a great surgical candidate. And then when we looked at his access sites as well, he didn't look like a great candidate for percutaneous therapies either. So very severe marked calcification. He had a subtotally occluded left axillary artery, but really looked at these marked areas of calcification in his iliofemoral system. He also had severe calcification in his coronaries, which I'll show you in a moment. You can see that when it's clear, there was left main disease, there was a severe circumflex disease, and there was a severe calcified proximal LAD disease. On his right coronary artery was occluded. Here you see the circumflex disease. And so, very complex patient with aortic stenosis, depressed ejection fraction, and triple vessel disease. So as his only option was percutaneous therapy, we used the peripheral shockwave to turn this artery that was subtotally occluded into this artery, which will then allow access and allow us to do a percutaneous procedure. This allows you really to tackle very complex anatomy in a very safe way. Clearly, we needed support. After dilating it with the shockwave, we were able to do a BAV, then put an impeller, and then through that single access site, which was really our only access site to do anything complex in that patient, we went on then to treat the coronary arteries using shockwave again on the proximal LAD and left main. And I'll just show you the final results. So here you see the final result after stenting and after IVUS guided post-dilatation. So I think I'm not going to show you any data slides. There are 2 studies that you can find that are published showing the initial experience in Europe with this called the DisruptCAD 1 and DisruptCAD 2 studies. There is also a study that's just been completed in the United States where this device is not available for coronaries, but only available for peripheral. But I think the experience has been very promising. And I think we now do really have a new weapon to use for calcified lesions that most interventionists can use and will feel comfortable using. Thank you.
Thanks so much, Azeem. That was a great overview. One quick question for you that is on a lot of people's minds is, how easily does the balloon cross? How often do you have to pre-dilate before putting the balloon down?
Yeah, that's a great question. And I think probably still the only limitation with this device. So to me, the profile of a shockwave balloon is somewhere between a non-compliant balloon and a cutting balloon. I think it's worse than a non-compliant, but better than a cutting balloon. In my own practice, probably in about 20 to 30% of cases, I need to pre-dilate with a smaller balloon in order to be able to get the shockwave to the lesion. You can, if you're really trying to avoid pre-dilatation, use guide catheter extensions and supportive wires that help. But I think in the future, we'd all love to see shockwave balloons with a better profile.
Yeah, no, that was a wonderful, wonderful talk, and now we've sort of seen the gamut of all of the atherectomy devices and plaque modification. So maybe one of you will tell me, do we need all of these devices in our cath labs? Didier, which one of these devices that you heard today do you actually have in Toulouse?
Yeah, so we have access to the rotablation device, also the shockwave. And I have to say that it's good to have multiple possibilities, because I remember a case in which I was not able to to advance a little at all the 1.25 rotablation burr. And it was a shockwave that did the job afterwards, after maybe 45 minutes of several attempts with all the support that I could get. So it's good to have multiple options for these very complex lesions.
Oh, really good point. Go ahead.
No, I was going to say, and because we do have orbital here in the U.S., I found that it's actually, there are cases where you'd favor one, there are cases where you'd favor the other, and it's better to have the both. Laser we use as well. I'm of the opinion that it's always better to have all the tools, because you'll always figure out where you would use some of the tools. And certainly shockwave will be a great adjunct to the armamentarium. We already are using the peripheral balloon off-label, with hesitancy, but we obviously have to use it in certain cases where the risks of other approaches, for instance, a stent under expansion, would be a challenge. Just remember, though, if you're going to use shockwave, old stents is different than new stents. It can actually cause structural damage to the stent itself for a new stent. So that's not the type of scenario where you want to put a new stent in and then use the device right after that.
That's right. So really important point on shockwave. And what about on shockwave? And we've seen, you showed us a beautiful case in periphery. I now see, these are the same kinds of patients who end up needing really complex work and even LV support. Holger, do you use? Have you used the lithotripsy for placement of large bore catheters, including Impella?
Yes, we
Holger?
have in particular used it for, yes, we have particularly used it for TAVI procedures or TAVR procedures where we are not able to bring in a large bore sheath. So in this case, we have used it for the periphery. And very similar to Didier, we have all these devices also available at our CAS lab. Maybe also important for the audience we currently have for the TIO conference we now have. So the orbital atherectomy is currently not available in Europe. So it's only what you have in the United States. So we in Europe only have currently the old-fashioned rotablation.
The first time that we're hearing that the United States has some device that you guys don't have over there, and it's just interesting. So I'll come back to you, Ajay, and I also want you guys and all of us. And this is supposed to be on calcific lesion, but the one place where we use these devices also, except for the lithotripsy, is in ISR, in in-stent restenosis. We've used it in our institution. So maybe you could just give a little bit of a rundown. We have 2 minutes before we go to the live case. And then maybe we can go back and ask Joost the final comment on what his big tip is on this session. Ajay?
Yeah, so ISR, remember, you got to figure out why the stent has restenosed, and it could be under expansion or it could be neointima. And if it's under expansion, then you need to expand the stent. You don't want to put another stent in. So imaging first. Then after that, in the old days, we used to kind of, with the stent there, try balloons first. If that didn't work, then contrast laser, then atherectomy with rota afterwards. And we were told that orbital was a no-no. Actually, nowadays with shockwave, because it's probably safer, that would be moved upstream. And then if that doesn't work, then you can try either contrast laser. And we of late have had some reasonably good experience with older stents with orbital or rota as well. So nothing's going to work great. And the bottom line is you just want to get the calcified lesion prepped the first time and do it right so you don't have to come back when it restenoses.
Joost, final comments on this? I mean, what do you think about that? The most common cause is a small MSA, and then they come back, and we've got calcium behind the stent now because we didn't treat it. You want to give us some last departing comments? We'll come back to you.
Yeah, so I think it was a great session, and I think what we can conclude is that it's important to really make sure you get a clear appreciation of the amount of calcium, pick the right tools, and learn the tools. I mean, it seems imperative to have at least some skills with a type of atherectomy device like rotablator or orbital, and lithotripsy definitely adds to the armamentarium in case there are very deep calcifications. With that, I would like to conclude. Image, if you can, test your final result, and go on with that.
So image, and think about the atherectomy and use and think about these calcific lesions. Thank you so much.